Hi, everybody. Welcome to Harm Reduction Crossroads, Navigating Gender Identity and Substance Use. My name is Gary Zavala Aleman. I am a licensed clinical social worker in Puerto Rico, currently in San Juan, and I also hold a master's in biomedical sciences. I am my pronouns are they, them, or she, her. I am part of the LGBTQIA plus community, and I also bring lived experience in substance use, tobacco use, alcohol use, and other intersections with mental health. I am also the project manager for the Tobacco Harm Reduction Education and Engagement Project at National Harm Reduction Coalition, which I'll talk a little bit about right now. National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. By involving ourselves in policy and advocacy, holding national and regional conferences. We provide trainings and technical assistance, also support programs with overdose prevention and publish resources and other publications in our website, harmreduction.org. And I will move on to Joseph so that he can introduce himself.
Thank you, Gabby. First of all, I actually want to thank Gabby for showing up here today. Unfortunately, my usual colleague here, Tanagra, is not feeling well, and she thought it best to sort of kind of abstain from today's presentation. And so Gabby just jumped right in, and I really appreciate her involvement with this. My name is Joe Pereira. I am a licensed clinical social worker here in Massachusetts. I have a private practice in Arlington, Mass. I focus on working with people around anger control issues, as well as people who are dealing with chemical addiction issues. And I have been really privileged to do to do these trainings with Tanagra for now. I think this is our third year doing this, so I'm really excited, as always, to be involved in training other social workers around these very important issues. Um, just to kind of give you what the hour and a half will look like is Gabby and I will kind of be going over some slides around issues related to care with gender identity and GLBTQ plus individuals and how to navigate that. And then we will be having a speaker, Che Vasquez Colon. They will be speaking with us around their experiences and knowledge about working with this population. And we're really excited about that. What we'll be doing is Che will probably open up with some comments, and then Gabby and I will be sort of going back and forth with some questions. And then, as mentioned, we'll hopefully have about 10 minutes for participants' questions. Now, that being said, for those of you who have attended our webinars in the past, we try to be interactive as best we can with a couple of hundred people attending. So I wanted to start off with an activity here. Um, so if we could go to the next slide, the evaluation scales. So it would be interesting to know from people and get a sense. So when you answer, read this question, I know what I need to know to provide quality services to LGBTQIA plus participants. Sort of where would you see yourself on this continuum right now? If you could put that in the chat box, and also kind of helpful for us to know. Um, great, thank you.
I see many threes,
Yes.
um, fours. Wow, love the engagement.
Yes. Yes. And it looks like we have some range of people from zero close to, I don't see, and I haven't seen any fives yet, but fours and a bunch of threes. So great. All right. I'm going to move on to the next question here. So, how I feel confident in my ability to provide quality services to LGBTQIA plus participants. And in answer to that question, I think there's a difference between knowledge and ability. And so you might have a knowledge, but still struggle with your ability. And hopefully this presentation will help with that ability. Um, so again, we see a range, although people feeling a bit more confident in their ability overall, if I had to do a quick scale there or quick evaluation.
Interesting.
Yeah.
Less very confident crowd.
Yeah. Yes. Yeah. 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 All right. So let's, if we could move on. So, for those of you who've been to these webinars, previous webinars that we've done, I certainly like this kind of model as a way of thinking about working with people. The drug setting model, which was developed a number of years ago by Dr. Norman Zinberg, actually based out of Cambridge, what was then Cambridge Hospital in Cambridge, Mass. So, in looking at this, so the notion of the drug itself that the person that you're discussing with the client or patient, how it's used, how frequently it's used, is it prescribed? Do they buy it kind of on the street? Is it legal or not legal? Those are going to be sort of all and each drug, certainly based on those questions, is going to have their own dynamic. In terms of, and we actually, our last webinar, we're going to actually be doing a more deeper dive into the different categories of drugs. And then the set is the mindset someone brings to the situation, including thoughts, moods, and expectations. So, kind of just in general, but now we're also going to be speaking about a specific population, which would kind of fit under that set category, because they're going to be faced with some issues that other people may not be. And then the setting. What is the physical and social environment where the person is in, and how is their perception of how that can promote or reduce risk, and not only their specific settings, but these days we really have to pay attention to the kind of the bigger political and social situation that we're facing, especially with this population. So again, I just think it's a really good way of sort of approaching this, and how these all intersect with each other.
And it's just a little note on that. It's interesting also that there is this effect, like it's shown in the Venn diagram. It's all interrelated, and
Yes.
I usually think about the drug, like the prescribed or street aspect of it, and the setting. Those two are something that could very much determine safety or risk, how risky it is to use that substance. Just wanted to add that little note. Um, all right,
Great.
so we are going to be talking about those intersections of identities and harm reduction and substance use. So we need to have common language. And so let's define what sex assigned at birth, gender identity, expression, and sexual orientation mean. So, sex assigned at birth, the phrase until the 60s, basically 1960s, it had been used to describe an obstetrician's casual pronouncement of the newborn as a male or female, strictly based on the inspection of the external genitalia. Um, it really then and now it's a designation that is put on a child's birth certificate and is sometimes considered the person's legal sex unless it is changed through formal processes. So right now, sex assigned at birth we usually refer to assigned male at birth or assigned female at birth. And we have intersex people who have a more blurry line. We could say in terms of the features and phenotype, which is what is expressed in their bodies. And so we have that, right? We have gender identity, and this is a person's internal, deeply held knowledge of their own gender. And everyone has a gender identity. I think that is really important for us to really let that sink in. Because cisgender people are people whose sex assigned at birth and gender identity correspond. So if you were assigned female at birth and you identify as a female, then that would make you a cisgender woman. And so in terms of transness, their gender identity does not align with the sex that they were assigned at birth. Two-spirit people is an indigenous term for people, again, who do not fit into these binary categories. We've got queer, and there's many more gender identities. And that makes us think about that gender expression, which is also not the same. Um, External manifestations of gender that is what the gender expression is. And these are expressed through name, pronouns, clothing, haircut, voice, behavior. It's everything that we can see about how this like we express ourselves. Um, and it's a broad spectrum, and we could mention masculine, androgynous, feminine, femme, identify as a femme non-binary person. And my that's my gender identity, and my expression looks very feminine. And so it doesn't have one thing does not necessarily have to correlate to the other. Which again, we tend to confound these terms, and I welcome questions in the chat about these clarifications. And that brings us to sexual orientation. It describes a person's enduring physical, romantic, or emotional attraction to another person. Um, it is, the identity is a person's understanding of the gender, and sexual orientation has to do with um, physical, romantic, or other attractions to other people. So let me give an example. Um, a transgender woman who is attracted exclusively to women would typically call herself a lesbian because trans women are women. And if she likes other women and is attracted exclusively to other women, then that would make her a lesbian. Um, and if she were the same transgender woman attracted to men, she would probably call herself straight or heterosexual, and so on and so forth. Um, and now, if there are no questions about this in the chat, I want these terms to be clear. We could move on to, um, some other aspects that we need to consider when providing services to these populations.
Okay, so if you can in the chat room, sort of based on maybe your own personal experience in working with this population, or what you could maybe imagine, what are some barriers LGBTQIA plus and gender diverse participants, what might they face when accessing healthcare? So societal pressures, concerns that providers won't understand or will be ignorant, bias and lack of understanding, affirmation of identity, microaggressions, bias, lack of law, defunding programs, concerns around misgendering, understanding bias, insurance not covering care, again, which has become much more of an issue, providers unfamiliar with their issues, ignorance, discrimination, misgendering, lack of understanding of gender issues, brushed off because it's a phase, interesting, provider political views, willful ignorance, bias and lack of resources being offered, fear, providers' religious views, right? Okay,
I wanted to
great.
highlight
Yes.
one
Yes, please.
comment.
Yes.
Cheryl Assa mentioned programs assigned for male or female. And
Right.
that's, something that we're going to continue touching on, but thank you for bringing it up.
Yeah. Provider notations in medical records, and participants being concerned about what may go into their medical records, which I'm assuming, Joni, you are referring to. Um, no HIPAA protections. Yeah. Re-traumatization in healthcare settings. Yeah, great. So a lot of, yes. So a lot of barriers here. All right.
Oh, was this my
Yes.
slide? Okay.
Yes. Yeah. Yeah.
Apologies.
Yeah. No, no.
Um, all right. Well, some of these barriers include stigma and discrimination, which, in other words, y'all mentioned in the chat, which are these negative attitudes or and prejudices from staff and providers. And so stigma is a three-part concept and which includes actions. And so we have the idea, the prejudice, what we think about LGBTQ plus people and gender diverse people. Then we have the attitude, which is how we start moving in the world when interacting with people that look a certain way or identify a certain way, and in this case LGBTQ plus and gender diverse people. um, Definitely, Joni, tremendous power differentials. And stigma is a tool of power, and control of certain populations. And that's, discrimination. And that goes into the actions that we are going to be talking about in the next slide. And so, other barriers, our lack of provider knowledge, which most of you mentioned, and because of lack of training, in specific health needs and terminology. And the last slide, which we'll share with, has a lot of resources. We will share those resources, and those are a good starting point to get oriented into terminology and health needs. There's also structural barriers, and these are the one of the most impactful. Intake forms and systems don't recognize diverse identities or names. And that is a problem because if we don't, um, make intake forms inclusive of all identities, and we include lots of races, ethnicities, then why are we not doing this for gender diverse LGBTQI plus people, right? um, and then there's also the fear of mistreatment. There are people, we learn by experiences, and if we have negative experiences, then every time we go to a doctor or any type of provider or clinical social worker, We already have that fear of being misgendered, like, some of you mentioned, just not being called by our chosen names, etc. So those are some of these barriers. And I'm gonna talk about structures of risk, which kind of go into the structural barriers. And so this slide is called structures of risk because the risk is not the gender identity itself, or the sexual orientation. It is produced by the systems around trans and gender diverse people, like I mentioned stigma, policy barriers, violence, poverty, unstable housing, healthcare discrimination, and denial of affirming services. And so for social workers, this means we should move away from asking, why does this individual use substances, to what conditions are making substances a tool for coping, survival, connection, or pain management. And so I'm going to talk a little bit about the peer-reviewed literature. It is growing, but it is still very uneven. Um, in 2024, a global systemic review of trans health research found that most studies were cross-sectional and relied on convenience sample. And the convenience sample is just picking the people who you have access to. So that leaves a lot of people that don't have access to providers or researchers out of the data sample. And so only a small share of the people in these studies reported community engagement and policy health determinants were rarely studied in this cross-sectional study. So there is enough evidence to see patterns of harm, but there's not enough longitudinal intervention and policy-specific research on substance use treatment outcomes for trans people. And where there's a gap in data and services rely on data for funding, then there's a gap in services. And on the substance use side, recent evidence supports minority stress and structural stigma framing. And a 2025 systemic review of transgender and gender nonconforming youth and young adults found very high substance use with stigma, social cultural vulnerability, and intimate partner factors that function as facilitators, while social support, pride, community connection, and economic stability have a protective factor. I think somebody raised their hands, or there's let me finish real quick with the slide, Samuel, and I will take your question. And I think that we had agreed that we were going to do questions at the end. I don't know if we could
Yes.
collect them
Yeah.
and type them in the chat. And that way we could take them all at the end.
Yes.
So qualitative studies that reviewed substance use as a coping tool and pointed to harm reduction and not punishment or gatekeeping, etc., as a more appropriate response. And I have the links to the studies at the end of the presentation. And so health and human right disparities are not they're not, you can't separate them. And so when trans people cannot safely use public spaces, update identity documents, access housing, or receive healthcare without being discriminated against, those are the conditions that become the health risks. And I'm just going to sum up a little bit of information in terms of the ACLU tracked in 2025. 616 anti-LGBTQ plus bills in the United States. Um, and out of those, 76 passed into law. And 97 bills were introduced in Texas, 38 in Missouri, 26 in Oklahoma, and more importantly, these bills, the 26 in Oklahoma, none of them were defeated. So they are actually just on the way to becoming law. And in Puerto Rico, the only two bills that were presented were passed into laws. One of them protecting religious freedoms, and basically, providers could discriminate based on their own religion. And the second law is protecting the physical and emotional well-being of children and adolescents by prohibiting medical practices that could have irreversible consequences for their natural development. And I'm quoting the law, just translated into English. And basically, gender affirming care is prohibited for minors in Puerto Rico, and that, there is direct consequences for providers who choose to do provide those services. And so that covers health and human right disparities, violence and victimization. It's not a background issue. 2026 JAMA Network Open Systematic Review and Meta-analysis of 94 studies found a very high global prevalence of interpersonal violence against transgender and gender diverse adults. And the most important aspect of this is that it includes lifetime physical or sexual violence, estimated at around 64%. Um, and, trauma, exposure, threat vigilance, and lack of safety can directly shape mental health, substance use, and whether somebody trusts providers enough to seek help. So I think that it's very important for us to keep this in mind. In terms of higher prevalence of substance use and mental health issues, evidence shows elevated burden, and the pattern differs depending on how substance use is measured. So if we don't come to an agreement of how we're going to measure substance use, then it's harder to quantify. An open study found transgender adults had higher diagnosed nicotine, alcohol, and drug substance use disorders than matched cisgender adults. Um, and there's another study showing higher lifetime mental health burden and highest risk among transgender non-binary adults. Um, the takeaway is not that trans people are inherently more likely to use substances, but structural stressors and service barriers are creating these conditions where mental health distress and substance related harms can concentrate. And last, we go to denial of services, which happens at multiple levels, going from the provider refuses care, and then take form, like we mentioned, erases gender identity. A residential program separates people by sex assigned at birth, which was also mentioned in the chat. Insurance excludes gender affirming care, or state policies like the ones I mentioned threatens clinicians with penalties. And a 2025 study of trans adults found that stigma and cost-related healthcare avoidance or delay was associated with depressive symptoms, anxiety symptoms, and intimate partner violence. So the fact that we are structurally denying services is having a direct impact on substance use and mental health for these populations. And yeah, I will continue on because if not, we'll never get to the last part. Okay, thank you, Joe. All right. So what do we do in terms of getting to know our clients? Let's use the names that we give you, how we give them to you. So exactly like that. If I say I'm Gabby, then you call me Gabby. If I introduce myself with the name in my ID, well, then that's the name you're going to use. But if not, then it's the name that I gave you. Um, Another important aspect of getting to know our clients, patients, participants is letting us tell our own stories and setting our own boundaries. And so trans people's and non-binary people and gender diverse people's relationships to, our bodies is none of our businesses. Don't assume, um, right, like that we hate ourselves or parts of our bodies. That just assuming that makes us feel worse. And allowing, trans people, gender diverse people to decide what it is, what is okay and what it isn't okay, um, is very important to, holding boundaries. And these boundaries are more important than our curiosity, right? And depending on the service that you're providing, if you're in a clinical practice and the person is there to talk about their image issues, dysphoria, et cetera, then that's a good place to ask questions from curiosity. If not, then that's something that we don't need to be talking about. And just a rule of thumb, if it's inappropriate to ask a cis heterosexual person, it's inappropriate to ask LGBTQI plus transgender diverse people. And I think that yeah, that is just the rule of thumb. Let's be decent human beings with regardless of gender identity, expression, or sexual orientation. And tips for when we make mistakes. All right. So first, we correct ourselves quickly and move on. Like if I call Joe she, I will say, oh, sorry, he, and then just, move on. Acting naturally. No need to overly apologize. And a good trick is to get it right in our heads 3 times. So just say he, Joe, Joseph, however he wants to be referred to, and then just move on. And I think that drawn out apologies, put people, trans and non-binary people in an unfair position of holding space for the person who misgendered them to relieve their own guilt. And, I feel like that's not something that we want when we want to build rapport with our participants. And
Okay.
yeah.
So just to follow up to Gabby on the tips for when you make mistakes, I would also add you're going to make a mistake,
Oh yeah,
right?
that's why it says when. It doesn't say
Yeah.
if.
Yes, exactly. So I think it's really important for people to know or to appreciate that we're going to make mistakes. And that's okay because certainly in my clinical career, I've learned most when I have made a mistake. And then the other thing I would say is it's really important to acknowledge it because I think in working with this population, they have oftentimes, a little bit of a generalization, been dismissed, ignored, blown off. And so in traditional sort of psychology, this notion of a corrective emotional experience that you are meeting with them, you're being on their level and acknowledging you've made a mistake and you want to make it better. And I think that just therapeutically is just so important for individuals. So for the sake of time, these questions, if you are working for an agency or clinic that offers gender services to gender diverse and LGBTQIA plus clients, if you want to put them in the chat box, that would be great. And again, just for the sake of time, we're gonna move on to the next slide.
All right. Well, some examples of LGBTQI plus specific services include, first off, they're not special treatment, and I feel like we need to keep that in mind. They are evidence-informed strategies that reduce these barriers to care. They improve engagement, increase psychological safety. Who, for clients who have historically experienced discrimination, healthcare, housing, legal systems, and substance use treatment. And these affirming environments research shows that basically they're associated with greater trust in the providers, improved retention and care, and better mental health outcomes for our transgender and gender diverse people. So these include, like I mentioned, trans-specific legal clinics, mentioned all of these bills. So we need to be able to navigate, the system. Expanded safer sex supply options, so different types of barriers, etc. Knowledgeable queer and trans staff. Thank you all for being here. You're taking a step into becoming even more knowledgeable. Gender neutral bathrooms, and I feel like there's no problem with us sharing bathrooms in our house, right? Somebody goes to your house, it's the same bathroom. So we kind of have to have that in mind when going into different bathrooms. And gender neutral makes everybody feel more comfortable with their own identities and expressions. And larger syringes for hormones and silicone, which again are also affirming interventions. And like I mentioned, knowledgeable queer and trans staff. And let's talk about barriers to
So I
care.
think we've we kind
Yeah,
of
right?
touched upon that question already, but the next question here
Oh, right. Yeah.
focuses a little bit more on. So again, very quickly, if you could put, so what barriers might LGBTQIA plus and gender diverse people who use drugs face when seeking services? So this is the other dimension that we're adding, and obviously the focus of our training. So if people could sort of put in the box, the chat box, sort of what might be the barriers. So societal stigma about drug use.
Detox beds, male versus female.
Yep. Judgment or fear of providers again. Triple discrimination. Yes. Stigma, fear. Providers assume HIV testing. Um, so I'm curious. It's too bad to elaborate. I'm gonna, Gabby, I don't know if you have a sense of
Yeah.
what Cassandra may mean by that, or
By what? I'm
providers
sorry.
providers assume HIV testing.
Oh, I assume it's because of the HIV epidemic and how we assume that queer and trans people wrongly assume or you know
Oh,
uh
right.
have it.
Okay. Yes. Great. Thank you. Um, the practitioner locates the problem in the person and does not address how culture and services create the problem. So again, that goes back to the drug set setting and really thinking about how of all of those interact. Okay. Why don't we move on?
All right. And so let's make our practice and services more inclusive. And, we need to be proactive for those purposes. The first, step is creating a safe environment, or, not safe, I would say a space where people can feel held in their vulnerability and heard and understood, because safety can be very, subjective. But in terms of that, yes, let's be proactive and not reactive. Um, why don't we ask everybody's pronouns and normalizing asking for people's pronouns and sharing our own pronouns in our introductions is one step to making gender diverse and trans people feeling more welcome in the space. Um, Creating these inclusive spaces also means we need to move beyond competency. And so every identity specific group has a culture, and you know it when you're part of it. And so we need to move. Um, away from that competency, which is the idea that we can learn about other cultures and become competent in those as we work together or provide a service. Um, to cultural humility, a term coined by Dr. Melanie Trevelyan and Jan Marie Garcia, which is a lifelong process which incorporates openness, power balancing, and critical self-reflection. And so another way to create inclusive spaces is building a network of support. And we could do that by recognizing, by being culturally humble when we don't have the knowledge or capacity or well competency to provide a service to a specific population, then we need to be able to refer. And so getting to know your colleagues and other services is really important. And to make sure that trans voices are heard is to, as well give a seat at the table. And in an organizational setting, it means like hiring people like trans and non-binary people to, also help build those networks from a lived experience perspective. Again, we need to avoid making ourselves, included LGBTQI plus and gender diverse people, do all of the work. And again, I said hiring because if you are going to have us do the work, then we need to get compensated for it. And now we can move on. I'm sorry I took over 2 minutes. We are going to move on to talk to our guest speaker. Che Vasquez Colon. They're a trans, non-binary nurse, spicy, death doula, community, a grief circle facilitator, and harm reduction practitioner from Boriquen, also called Puerto Rico. They, their work centers on liberatory harm reduction, housing justice, and equity-informed organizational support. And after 10 years in the diaspora, they returned to Boriquen in 2024 to co-lead a community-based harm reduction program. Fun fact, she is also a writer and mixed media artist who enjoys moments of stillness, flowers blooming, and witnessing queer trans joy. I will let Che speak, just do a brief intro and then we'll move on to questions.
Thank you. It's really good to be here with you all. And thank you for that introduction. I have yeah, neurospicy is a really good way of describing all the diversity that lives in my brain. Um, so yeah, I have a background in psychology. I also identify as someone who uses drugs and have lived experience with the various like uh, institutions and work on harm reduction spaces. I wanted to kind of like say that we're gonna be having like heavy questions and talk about more in detail about the harms that can happen within the services that you all provide, um, while also acknowledging that queer joy and trans joy is possible and it is not to like I think it was mentioned before, right? Like we are not all like the same. We have different experiences, and also our intersectionalities play a really big role. So while we talk about the trans experience or the like gender diverse experience, thinking about how race, class, disability, and all of those things like play into the barriers that folks may experience, and also taking a chance to your own self-reflection around how your privilege and power positionality may also play and influence your approach and engagement with folks. And I think that's my intro. I know I'm gonna answer a
Thank
bunch of other
you.
questions, so
Yes, yes,
let's
Yes,
do it.
great. Thank you,
yes.
Jay. Yeah.
Thank you so much.
Yes.
So to get us started in the conversation, I know that I mentioned a lot of stats regarding legislation, but could you speak about how the current political climate is impacting and or hindering access to services for trans, non-binary, gender diverse folks?
Yes, I can. And thank you for bringing up the ACLU like map tracking. I think it's a really useful resource. And I am not going to go in detail into all the bills, but there's a bunch of them. And I do want to say that our system is not broken, it's in functioning as it was intended, and that is to protect white, cis, hetero, for the most part, male, and how that also plays into colonialism and the imposition of gender. Because gender is a construct, right? Like we were saying and expressing before. So really taking into consideration that the system is oppressive for folks who are trans and also oppressive for people of color and with different intersectionalities. And it does have a huge impact in how we relate our mental health and our ability to thrive and access services that align with our needs and also that needs financial access. So it's not only about we cannot use the bathroom that we are wanting to use, it also impacts a lot the ability for folks to thrive. And there's a lot of high suicide rates within our community. And I think that that's important to always keep in mind while you're also engaging with your client, participant, patient. Do not forget that the social context really has a big impact and limits our ability to access care, especially among like young people and like folks who are wanting to pursue gender affirming care. Surgeries are really expensive, and right now we are seeing a big impact in healthcare access for folks who want to pursue gender affirming care. So really knowing and be familiar with the current context, which is not new. It's just more visible now and maybe, more targeted. And transphobia, it's not a phobia, it's violence. I think that we need to name it as intentional violence. I don't think people are afraid or have a phobe against like us. It's just violence supported by the system and by our society. So that's all I'm gonna say. Like, that's a lot.
Yes, it is, Jay. Thank you. I'm going to ask the following question, but
Yeah.
very quickly before I do, this is an hour and a half presentation. There
Mhm.
is so much, we could probably spend a week on this topic. And so I just encourage, there are some resources for people that
Mhm.
this is not the end all or be all of your education around these issues. And so I would just encourage people to do more sort of research or training or learning about these issues. So I just kind of wanted to put that out there because, these questions, not to put Jay on the sort of the seat, it's like, okay, you can tell us everything that we need to know in 5 minutes, and that's just not a reasonable request. However, with that being said, for someone who does not have a lot of background working with trans folks like myself who use drugs, what would be three key things that I should take into consideration in order to provide culturally humble and responsive services?
Thank you for that question. Going back to the mention of compiling research and available resources, specific trans-led programs and services in the community, it's really important as a provider, especially knowing that the services are very limited. And not only doing like, oh, this is the link, but actually connecting with the organizations and programs to get to know them and know that it is like like an affirming space for folks before referring. Um, and like we mentioned before, related to services like drug treatment spaces or like support groups are really gender binary based. So getting to know how to talk with your client, your patient about the limitations or around how those spaces look, and being mindful if there are other resources that folks may pursue if they're wanting to get some sort of like treatment or services for their drug use. Um, Second, I think that exploring with curiosity what folks' relationships are to drug use and as it relates to their gender identity, without assuming, right, that all trans folks' experiences are the same. It was mentioned before, but often it is used as a coping and survival mechanism. And folks, may use stimulants to be awake, and not, get their stuff stolen or like be able to produce or work in their different like settings. And also just explore that relationship, right? With curiosity and not with added stigma that folks already receive. And I would say, to wrap up that, to just be mindful that people's like social context and support networks are very different, and that we don't have necessarily the traditional support systems like you would think of a traditional family. So really doing an exercise like called pod mapping. I can put the link later, but really identify what are the support systems of folks, um, without assuming, right, that they have the support
Mm.
already. So yeah, that added to all of the things that we already talked about using names, pronouns, and just like
Mhm.
being humble about folks' intersectionalities.
Thank you.
Thank you, Chet. So you mentioned humble, and yes, I just in your experience, and we don't want horror stories or to talk about some deep harms, but what have been some of the harms that have come from clinicians or providers that are not providing culturally humble or responsive services?
I think that not having like gender affirming intake questions and processes, it's what, in my experience, like begins the whole like resistance and saying like, well, I'm not included. Where do I place myself? And also the idea of like we have to name a label, right? Like we have to identify with a label, but having different options for gender identity and the ability for us to name our preferred name and pronouns. It's really important, and I often don't see that in any of the clinical settings that I have been in. And last time I was in a doctor, they said like, well, the sets meets it's this data, so it's like either male or female. So it's also like how we word and how we phrase things, and that can really, deter people from seeking services and contributing also to the already invisibilization of their experience, and like not wanting to pursue like any medical care because there's this increased idea and feeling that no one will care, right? Like, and there's already the compounded impacts of the structural exclusion and the stigma available. So really being mindful of how that like interplays. And if we are there to see you, that means that we might be already struggling. So really not trying to not contribute to that further like harm, because it is really harmful. And I think that it really places folks into like a life or death type of situation. So yeah.
Thank you.
Good. Thank you. So, Jane, based on your experience in using the context of the drug setting model, do you, based on your experience, do you think that there are certain substances or drugs that folks who also identify as transgender, nonconforming may be drawn to, and if so, why?
Um, so I think that was a little bit mentioned before, in terms of like the disproportionality of like drug use amongst the LGBTQ plus community. And for me, it goes back to that kind of like minority stress theory and the social determinants of health and how folks' environment like impact their ability to cope. I would say that alcohol is very prevalent amongst the community. Tobacco use is very prevalent. The use of stimulants as well as a way to be able to engage, to stay awake and prevent like violence against trans folks and also, as a tool for folks who engage in sex work, that it's also like very prevalent within the trans community because we don't always have access to traditional employment. So I think like drug use, exploring that relationship, is really important and how it is impacting their day-to-day life and how it's a part of a benefit and also maybe a harm, but that would be up to the person, right, to identify that. But we shouldn't assume, right, that it is a problem and people's experience is their own and their autonomy is important and exploring the relationship with whatever drug they're taking without adding to that already stigmatized and criminalized environment would be really important. So I don't think it's a particular maybe drug specifically, but all the factors that may contribute uh to drug use and all of that.
Can I just, sorry, Gabby, just to follow
No,
up a
yeah.
quick question. I'm guessing, and Che, that a lot of times drug use is, or what's being used is geographic. So, what may be common in California is not common in New York, and vice versa. So,
Mhm.
I'm guessing that also may contribute to what people may be using. Is that fair to say?
Yeah, that is fair to say. For example, like meth, like methamphetamines, crystal was also a name. It's more common in some of the states, but in Puerto Rico, that drug is not as common. It is here, but it's not as prevalent. So I think that it does has a big impact in where you're located and the access that you have.
Yeah.
Um, yeah.
Yeah.
And
Thank you.
I also wanted to add that, I was thinking of you mentioning stimulants, and it also has to do, why would we need to stay awake for so long? Well,
Mhm.
if we have to hold down three jobs to survive, then, that's again like the structural aspect of, all right, well, I'll need three jobs and I need something to keep me awake. So, I just kind of wanted to
Mm,
throw that in there as well,
right.
as part of this spectrum. And
Yeah.
so, talking about, we're not going to stop people from using drugs. Drugs are there, they're always going to be there. And if what are three recommendations you would offer clinicians or providers that want to integrate harm reduction into their practice, working with clients who identify as trans?
Um, well, I think like harm reduction in general, it's also like body autonomy and like gender affirming care is that also. So really knowing what gender affirming care is, what are the options and how does that relate to their drug use or their gender identity. Um, knowing that it's their like it's their decision, ultimately. And I think going back to what I said earlier, one of the ways would be just to openly explore what's their relationship with their drug use as it relates to their gender identity and also their context. Like you mentioned before, like, we need to stay awake, we need to hold three different jobs, like exploring that relationship and how if they want to reduce that or replace that, how would that happen? And what are the stressors and factors that might be preventing or impacting that? Um, I think that harm reduction in general is just people center. Like again, not assuming that all trans experiences are the same, and how the intersections of like race, disability, and all of that plays out. And what has mentioned before in the chat, right? Like, what are the services that are not based on a gender binary? And that's very limited. So, like, really looking for options or integrating, gender affirming like toolkits, like the one Gabby put in the chat, to your care. So you are like mindful of what's out there or how you can integrate that, and also asking people, and integrating their goals and gender identity goals within the conversation. I think it's really valuable as well.
So what I'm gathering is
Thank you.
um just making just to land the point of harm reduction in general. What I'm gathering is respecting body autonomy and integrating gender affirming interventions into the services. Is that starting
Yes.
from language intake
Hmm.
and everything else that you mentioned? Um,
Yes. Thank you for lending all of my my
so
or
good.
disorganized
Great.
thoughts.
Yeah, no, 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 all good. So, okay, I could say, all right, this is all fine and good, but I don't really work with this population. So, why should clinicians care about deepening their knowledge, right? And skill set around working with trans clients who use drugs? How do you think it might just enrich their practice in general?
Well, I think that thank you for that question. I think that the same way that you go through your master's and licensing to get to know or the interventions and approaches that are like standardized, I think the same way it is important to deepen your knowledge about different communities, not only the trans community, and also like we are not like this whole different like human, right? Like we experience similar emotions. We are living in, relatable context. So really understanding that, it goes back to that cultural humility piece and recognizing that it does enhances your practice and allows you at the end to be able to provide care to more people in a way that is compassionate. I think that for me, like having a clinical social worker that could hold my process in wanting to get top surgery was really valuable. And I was looking over like some of the documents in preparing for this, and you know, social workers do need, or your any therapist do need to provide a letter if folks are wanting to pursue gender affirming surgery. And it goes back to like a diagnosis like of dysphoria, and also stating that you are well enough mentally to understand the process of that. So I think that if they weren't able to understand that and hold that for me, I wouldn't be able to pursue my gender affirming surgery. And I would say that that saved my life. And I think that really knowing that you are an important factor in someone else's well-being, and it's really, it's really important. And I think that when we talk about drug use, also understanding how those interplay with like hormonal therapy treatment, with preparing for surgery, and how you can just like talk about that process. I was hesitant to, for example, receive opioids for pain management, and I was asked to stop all drug use, alcohol, weed, all of it, like 2 weeks before surgery. So, like, how do you talk about folks in
Yeah.
preparing for that, and having those conversations, and also knowing that there's gonna be a diagnosis attached, which I didn't know at the beginning, and talking with people about how does that feel, And I think that at the end, if you don't feel prepared or like competent to provide the services, just please recognize that. I know our egos can be pretty up there, but it causes more harm than good if you don't know how to provide appropriate care for folks. So do ask for feedback. We like to give feedback. We like to be asked. Um,
Mm,
and if not, please do refer. Because I think that it's important that folks get the care that they need.
great. Thank you.
Thank you. And I think that you kind of started on this last question, which is, can you share an instance where you have worked with a clinician that has demonstrated good clinical skills with a trans person who uses substances, and what made it that it was a good, clinical skills practice?
Well, those have been very limited, I would say. But like I mentioned, my social worker, like therapist a few years back, um, really provided a container for me to explore and pursue the care that I needed. Um, and also without saying, oh, like you're too old, like why didn't you figure this out earlier? Because I started my process around my 30s. I'm 34 now. And I was like concerned of like, oh wait, I like I am old for this. Like usually it's like younger folks, and like how does that would play into the perception of my provider and people around me? But she was very like curious and just opened the space for me to talk about it. I would say that substance use in my experiences have been like, oh, you should stop. Like it will be like abstinence based. But they did ask me my relationship with like drug use and in preparing for surgery, where were my, my fears or my worries. And also how to coach me or prepare me to talk with my surgeon, like
Hmm.
the person who was going to operate me. I'm
Yeah,
sorry,
surgeon.
Spanish and Spanish and English always get confused. But I think that really, just respecting my name and transition, not questioning it, not adding to barriers, and being very open to get familiarized because they didn't know much about working with trans folks, but they did the research and they were able to write me a great letter and support me through the process. So I think that, you know, getting familiarized with it, asking, respecting, not questioning folks' decision, and also prepping folks to, assess their drug use and how that may impact or not their process if they're wanting to pursue gender affirming care or other like services.
Great. Thank you. Thank you. Thank you, Che. So we have some time now for people who are participating to ask questions of Che. So please put them in the chat room and we'll take it from there.
I'm gonna stop sharing the screen so we could see each other for this section.
Great.
Better?
Yes.
Okay, here we go.
Thank you. Thank you, Gabby.
Of course. Um, so questions for Chef for us. Um,
Just a reminder to everyone to please add your questions in the chat. If you would like to ask a question anonymously, feel free to send it as a private chat to me, and I'll be happy to read it to everyone.
So a question from Alan. Given the political legislative impetus regarding irreversible treatment in gender affirming care, what is the irreversibility or reversibility of hormone-centered care?
so uh, that feels like a um more scientific like definition of what is reversible, but I'm taking just a stab at it for you to have any other ideas. But this makes me think about when, femme or assigned female at birth people go through menopause or other, or pregnancy, etc. Those are irreversible hormonal processes that occur naturally. And, some most of people going through menopause have to take hormones to supplement, that lack of that previous those previous levels. So we would have to ask a medical professional like what irreversibility or reversibility means. So I don't know if that kind of answered some of your question. This was basically a lot of I don't know. I don't know. This is what I'm guessing.
Yeah, I would maybe if I'm understanding the question, but I would add to that, if you stop taking X hormone, that being like testosterone or yeah,
Estrogen.
estrogen, estrogen,
Estrogen.
uh, um, your, it has an impact on how your body looks, how your body feels, and it can have like a huge impact on folks like mental health and ability to express themselves as they want to. And that's attached also to like the lack of access right now for hormonal treatment and how it's impacting folks in reversing or like stopping their treatment because of a lack of access. So, it is scientific question we should ask the
Mhm.
doctor, and also the expression of folks will be modified, and that can have a huge impact in their journey for their gender identity and expression.
And it also there's a lot of nuance to this because some people take blockers and not like hormones per se. And so that also has a different impact on, what that I'm going to be very scientific phenotype looks like. And so it's how these hormonal balances are expressed. And what I've heard from like firsthand accounts from people that are on blockers is that basically and this was from a trans woman, they are not being like more feminized. They're just stopping their own body from being like more masculine. And so that also has, a different impact versus if you're taking estrogen versus if you're only taking a blocker. And again, this is a more medical term, but yeah, thank you for the question. And maybe if you want like a little bit more of the political or legislative aspect of it, if you could refer to the specific law or mandate that you are referring to, Alan, that I think that would be helpful as well to understanding a little bit more the question if what we answered is not what you were looking for.
There is a more general question from Brooks. Can someone review the concept of harm reduction regarding using substances?
Can someone review? So,
The concept, what does harm reduction mean in the context of substance use?
all right. Well,
So,
I mean, if you want to talk about it, or I could talk about it.
We can both like kind of answer. Thank you for your question. Harm reduction, it's like principles and strategies to reduce the harms associated with different substance use. It's centered on people's autonomy and people's like choice, valuing like dignity and humanity, and it understands that drug use is gonna it can be present regardless, and the aim is not to uh, seek for abstinence, although abstinence can be part of the approach. but to reduce the harms. Like, for example, if someone is using like injectable, like IV, intravenous, like drug use, in the program that I work with, like we provide like clean syringes, all the things that they might need in the process of injecting the drug. So it's like safer, like it's not sharing used needles to prevent different like diseases. It can be also talking about how to safer inject, like how to find the vein and how to do that like safer. And it can include other paraphernalia as well. Gabby, you want to say something? I
Yeah,
see it.
I want to highlight that
Mhm.
it is like harm reduction is a movement for social justice, whose roots emerge from BIPOC movements demanding equity and justice. And it is harm reduction is also care work. So we
Mhm.
are um respecting people's autonomy, meeting people where they are, and not leaving them there is the second half of that statement, which is you're not ready or unwilling or haven't even considered your use as a chaotic or problematic or diagnosable, if you will. Well, we're meeting you there, and then we are giving you options as to how to mitigate the risk and the possible harms of that use. And that is care work. And, us as social workers, we have to care for our patients. And if we don't meet them where they are, we won't be able to get them to where they want to be. And understanding, like we've mentioned throughout, the relationship that people have to substances, the why, the what, why, how, those questions are really important. And that is what harm reduction is. It's not just a public policy, a public health mandates, if you will, or way of looking at drug use, but it's also a movement for social justice where we need to have, access to everything that everybody else has access to. And yeah, it takes into account again the racialized war on
Mhm.
drugs, which we know that prohibition has targeted, Black and Brown communities in the U.S. And yeah, we can talk all day about the war on drugs, but that is basically what harm reduction is. And I'm gonna drop a link into the chat for you to read more on it from National Harm Reduction Coalition.
Yeah, Gabby, I was just going to follow up. I think for those of you who haven't, I think the National Harm Reduction Coalition, the website is a great place for information on harm reduction and the work that's being done, not only in the United States, but in other parts of the world. So it would be highly recommended to kind of access that website. Maybe we have time for maybe one more question. Um, I know that somebody earlier had a question. They had raised their hand, but I don't know if the question was answered, so they don't have the question anymore. But
We didn't receive a question from the person that had their hand raised earlier, so I'm assuming maybe their question was answered.
okay, thank you. So one other, Gabby, can you very quickly do the screen again?
On it.
Thank you. So again, very quickly, if anybody can sort of in the chat box, what is something you're taking with you from this workshop that might have resonated for you and may influence how you sort of navigate these things, these issues? Cultural humility versus competence. Yes. Hope. Great. Harm reduction as it relates to social justice. Yes, that. I'm assuming referring to the other one, deeper understanding and empathy. That maybe I doubted my ability to actually provide care in the community and know more than I expected. How the system, I'm just jumping here, how the system impacts substance use rather than substance use impacts the person.
Barriers
Important,
that gender
yeah,
diverse individuals who use drugs can face in healthcare settings. Appreciate
yeah.
that, Amy. Drop that. Thank you, Amy.
Advocacy, personal versus systemic barriers. Be careful when working with folks who are using substances and are LGBTQIA plus. Follow their lead. Awareness to listen and advocacy. That's great that people are uh, using that a takeaway. Understanding and awareness. Appreciate the use of language and to meet folks where they are. Understanding my comfort level and implicit bias, reminders of minority stress theory bottles to help educate other professionals. Great. Well, I certainly want to thank Che for your participation and your comments. And Gabby, thank you again. Thank you for stepping in. Really, really appreciate your knowledge about this issue. Um, and I
Thank you
think,
for
yeah,
having me. I
Yeah,
really
thank you.
appreciate having, the honor of sharing space with both of you. I'm just glad. I have very big shoes to fill with Anaga's is an amazing facilitator. Hopefully, I did her justice. And thank you, Che, also
yes, yeah,
for,
yeah,
your knowledge and experience.
yeah.
Yeah, thank you both and everyone who joined. And also like queer joy is important. This is bringing me joy, and I am glad that you all like participate and engage. So you know, keep moving forward and learning because it is really important. So thank you.
Great. Thank you. So,
And I
Chris
know that
Belly,
we
I
have,
think you're
yeah.
going to come on and give us the all-important number.
Yes, I am. I wanted to thank our speakers, Gabby, Joe, and Che. Thank you so much for joining us. This has been a very much needed presentation. So thank you so much. And we're very excited to be seeing you again next week. Just a reminder to everyone, this is a 3-part webinar. We're going to have one on May 28th. And I believe the other one is happening on June. I'll send everyone the dates as well.
June 9th.
June 9th. Okay.
Yeah.
And that last one is going to be 2 CEs. All of them are free webinars and they can also be attended as standalone. So it's not that you have to participate in all of them to receive credits.